Okay, so today's presentation, today's talk, today's hangout or broadcast or whatever we're calling these things these days is going to be about balance disorders. It's going to be about balance disorders. What causes balance disorders? Most people think it's like the ear, and a vast majority of the time the ear is not the primary mover and shaker in your dizziness or vertigo or balance problem. And we're going to talk about the types of things that can be done to improve those. And this is one of my favorite subjects, so I'm probably going to have a little enthusiasm going here today. I'm Dr. Martin Rutherford. I am a chiropractor, and I am a certified functional medicine practitioner. My brain is working good today.
Great. And I'm Dr. Reno Gates, board certified chiropractic neurologist, as well as being a chiropractor.
And we have a practice in Reno, Nevada, and the practice is kind of interestingly developed from into a chronic pain and a chronic condition practice, of which balance disorders can be chronic conditions. And we have married our two disciplines, because these are two very distinctly separate disciplines. You can even argue we've married three disciplines with the chiropractic involved, but we've really married functional neurology with functional medicine to address pretty successfully a number of different chronic problems. Dr. Gates studied with a Dr. Ted Carrick.
Ted Carrick, yes.
Is that how he is online? His name's Frederick online.
It's Frederick, but
I'm just saying that because a lot of you like to look it up. He goes by Ted, but his name's Frederick online when you look him up. Yeah. But it's Frederick Carrick, and he was the developer of the discipline of chiropractic neurology. And I mentioned that because, if I'm not mistaken, he kind of started out with dizziness and vertigo and balance. Wasn't that like the main?
That was one of the main emphases that he had
along
with his development. And now he's gone primarily into concussion and traumatic brain injury. That's where he's doing a lot of his work.
So the bottom line is Dr. Gates kind of cut his teeth on this subject, so to speak. And I find it an interesting subject because, and let me lay out some of the parameters. Dr. Gates is now in our clinic does 99% of treatment, and I have been able to step back. I've been in practice since 1980, and I've been able to step back and help out by doing more of like screening patients, making sure that when a patient comes here, that they're a good candidate for what we're going to do. Insurance doesn't pay for what we do, so I want to make sure if that person is going to be coming here, they're going to be investing their hard-earned dollars, they're going to get a result. So we do a pretty good screening. And one of the interesting things about balance disorder patients is sometimes I'm not sure people get how, I think we need to kind of go over, I see what we're going to go over here, but one of the things I want to bring up at some time during this, or maybe now, is folks come in and they all think that everybody else who has balance disorders is getting better except them. When in reality, probably most of the people who have balance disorders who have gone to the doctor and are taking the medications are going to take those medications for the rest of their life. And that's okay if it's working, but obviously we get the people for whom it's not working very well or they're getting worse. But the other thing I see is that when we start talking about the types of things we're going to talk about today, and that's why I'm excited about this, so that we can direct people to this particular hangout or presentation, whatever, then they can get a better idea of why it's not just about, a lot of people say, well, I can live with it. It comes, it goes. Yeah, it's getting a little worse. Well, the medication helps me. Why should I have to go through 1 or 2 or 3 or 4 months or whatever I need to do to resynchronize my brain? And I would like to kind of maybe have that as a framework against what we're going to talk, because when I'm doing the consults, that's really what I am. Those are the answers I'm trying to give. Those are the questions I'm trying to give answers to, relative to, well, what if I don't do this, and so on and so forth. Now, there are probably 18 different types of dizziness, vertigo, and balance problems, or maybe not that many.
I know there's more. And
there's more.
Basically, to answer your question, I would say it's all about what type of quality of life do you want to have. I mean, if you just want to take meclizine or Valium,
there you go.
And be basically those medications, in essence, calm down the signals from the inner ear, Lots of times they have a depressive effect on brain function, so a person will just kind of feel a little out of it, a little groggy. If that's what you want your quality of life to be, and there's nothing wrong with that, and medically that is a successful treatment option, then that's fine. We had a patient who I was just talking to on Sunday, I haven't even told you yet, very successful business person in the upper echelon of the 0.0001%. And she had a vertiginous condition, a Malday-Embarkment syndrome, where she felt as though she was moving after she went on this long sea voyage down to a certain location on the planet. But basically, she got off the ship and she was still moving. She was still moving. And her response was, "You've given me my life back." Yeah. Because now she no longer feels like she was moving. And trust me, she saw the top neurologist in the world, because basically those types of doctors are at her disposal.
She's able to access those.
Yeah, access those doctors. So anyways, so that's a perfect example. We like the tougher cases of balance or lack of balance. We like the tougher cases of vertigo where it's still there after a long period of time, because those patients are suffering, and lots of times they do really well and they see a dramatic difference with our therapies.
Yeah. Consistently.
After properly selected.
So that's perfect. That's actually a great answer, and it's something I'm going to be able to use when I'm communicating with people. I do a lot of talks. If you've seen online and you've looked online, I do a lot of talks online, and I'm always looking for better ways to more simply communicate complex issues to the lay public, and that's kind of my job at this point in time. So let's get into balance. There actually are some very simple balance problems like BPPV.
Yeah, absolutely.
We'll get into that in a few minutes, because everybody that walks in here knows what BPPV is, because no matter what they've had, they have at some point been diagnosed as having BPPV.
And they've done the Epley's maneuver.
So we're going to get into that, because you have to get into that, because everybody who has ever walked in here has said, "Well, I think I got these rocks in my ears," so we'll get into that. But what gives us good balance? Now, I've done a whole talk on this. Is that talk online? Is that whole talk on vertigo, dizziness, balance? So it's online. I've done a whole talk on this, but that was like 3 or 4 years ago. And
we did one earlier this year too.
And we did do one there. I was going to ask, haven't we already done this?
Yeah, we have.
Again, we've done one earlier this year.
But this is specifically on balance. So we're not talking about vertigo as much. We're going to have to discuss the balance.
Okay, so we're going to talk about balance. You can tell how well prepared we are.
We're very well prepared. We just didn't communicate on that.
So we're going to, all right, so we'll go specifically with balance, but I think, a pretty good job on that balance, the dizziness, vertigo thing, on describing balance. But it's a pretty cool thing as to what causes good balance. Everybody thinks it's the ear.
Right.
And I'm going to kind of like now start to deflect everything over to Dr. Gates, because this is a fun talk or a topic, because so many people have it. People don't know what to do with it. They don't even know if anything can be done for it. They don't know all the different manifestations of it. Everybody thinks it's my ear, right? Sometimes. So why don't you take off with what gives us good balance?
And to finish that last point, in essence, we have to talk about dizziness to talk about balance.
Yeah.
Certain conditions cause that, because people say I'm dizzy and I'm out of balance, or the room's spinning around me and my balance is off. So those things have to be addressed. So what causes good balance? In essence, balance, think of a symphony. We have multiple different instruments playing that come together to produce this wonderful melodic sound that we all enjoy. That is what balance is. Balance is just not inner ear function. It is not just sensation from the feet. It is not just sensation from the neck, which has great importance.
Which virtually almost everybody that's watching this has no idea.
Has no idea, exactly. But we're going to go into it. And then it's also visual information. So many of you may have recognized that, man, when it's dark out, my balance, gosh, I really got to grab onto things, or in the middle of the night, go into the bathroom. So your brain has to assimilate all these different signals from the eyes. Believe it or not, you have receptors in your neck. The receptors in your inner ear, known as the vestibular system. And then also sensation from your feet to create this picture of where you are. It's called spatial awareness. It's really interesting. We're doing a lot of talks on concussion right now too. Spatial awareness is one of the first things that goes when somebody has a major blow to the head, because it's such a complicated.
Meaning, you don't know where you're.
You don't know where you are. You don't know where you are relative to your trunk.
Kind of knocking into things, or
you're a Boeing 787.
Or you think you're here. You think you're walking down the. You think you're walking down the hallway, and you think you're here. Your brain thinks you're here, but you're actually here. So you it sounds complex, and probably is, but so you start bumping into things and stuff like that.
You have a Boeing 787 flying over the Atlantic Ocean without all of its instruments or the right computer software to put all that together. And so that is how complicated this whole system is. Much of our brain is dedicated to balance and preventing dizziness. So, and you know, a lot of what people will say are the older systems in the brain. However you want to look at it, whether you believe in evolution or not, or you want to look at how a baby develops, these balance systems are the first things to really come online, so to speak. So those 3 to 4 major things give us good balance. So again, it's the visual information, inner ear, feet, and the neck.
And aren't there balance mechanisms in virtually every joint in the body?
Yes.
Proprioceptors.
Yes.
They have to also, you talk about the feet, the neck. I mean, just to emphasize what Dr. Gates just articulated is, I mean, it's all about balance. It's not about just the inner ear. It's about every joint in your body. It's about you having bad posture. People have scoliosis have bad balance because they have a curvature. They have all these called proprioceptors, balance mechanisms, and every single joint there. It's hard for them to overcome the structure to balance. I mean, it's a complex issue. It's a full body issue.
It is a full body issue.
Yeah.
And I really feel that's why Dr. Carrick, in part, has done so well with concussion, because, as I mentioned, spatial awareness is a big thing that's disturbed in concussion. And really, if you get the person's balance back, not only does their spatial awareness come back, but lots of times in other parts of their brain function, like thinking clearly, tend to come back too, because the balance system is a generator for our frontal lobes, which is where we think, that's where we our personality comes from, things of that nature. Okay.
Well, I'm good.
Addresses that.
So now that we've bagged on inner ear conditions and saying that they're not, you know, the only problem, why don't we talk about inner ear conditions when they are affecting balance? Because we're not saying they never affect balance. We're just saying that there's a lot more to it.
Yeah, they're just not the only thing. So basically, as Dr. Rutherford mentioned, BPPV is on the tip of everybody's tongue. Anybody who has a balance condition comes in here talking about BPPV and asking if they have it and wanting us to test them for it, which we will. But BPPV does occur. It's where these little rocks in our inner ear system, which are normally there, that help us to sense where gravity is pulling us from. They can dislodge and go to another part of the inner ear where they shouldn't be. And then commonly the person lies down or they roll over in bed. All of a sudden the room will start to spin for 30 to 45 seconds. Then after that they'll commonly feel nauseous. Usually they won't vomit, and they'll feel out of balance for a certain
And if you get the vertigo and the dizziness that we said we weren't going to talk about, you're going to have bad balance.
Right, and then you're going to be off. You're going to come in and say, my balance is off, please help me. So that's BPPV. Then the next one we probably want to talk about is Meniere's disease. Meniere's disease is where the inner ear swells. The current concept is that the inner ear is not draining the fluid out of itself, and so that causes the swelling, and that can cause not only symptoms of vertigo and lack of balance, it can cause someone to feel as though they're being pushed down, as well as them also to have ringing in their ear, fullness in their ear, things of that nature.
Loss of hearing?
And loss of hearing eventually. Oh, gosh, we came up with a great article today on Meniere's disease. We need to attach it to this. If you want it, email us or contact us on the web. But basically, they're saying how these second echelon treatments for Meniere's disease, like going in and poisoning the inner ear with the gentamicin antibiotic, or scraping the entire inner ear apparatus out, none of them were more effective than the other one, which is interesting because we have had Meniere's patients who were considering those therapies. So anyways, that's a tangent, but that's what we're talking about today. So another really common inner ear disorder is vestibular neuritis, or neuronitis. We just saw one yesterday. Actually, we had a patient come in. And that is where lots of times there can be a viral infection, and the immune system can get overreactive to the virus and start killing the vestibular nerve, the nerve that sends the signal from the inner ear to the brain.
The balance nerve in the ear.
And so as a result of that, a person can feel off balance, and that's exactly how the person presented yesterday. She said, you know, I'm not really throwing up or anything like that. She said, I'm really off balance, and the room's kind of spinning around me. Well, she had vestibular neuritis, so we're referring her today for some medical treatment of that, because there are certain medications that you have to get the person early on to prevent long-term damage.
And we're not medical doctors, but we work in an integrated environment. We work with We will work with most people's medical doctors if they're willing to work with us when necessary. However, we do have doctors that embrace what we're doing and work with us as a team. So we have more or less an integrated approach. We have a couple of osteopathic doctors who are conversant in certain areas that are very helpful to us, that are in our practice a couple of days a week.
Yeah.
And so we embrace a full integrated model to address the different types of chronic problems that we have. And we use them when they're needed, and we don't use them when they're not needed. So that's kind of how that goes.
Exactly.
And in this particular case,
we're referring her back to her GP, actually, because
that's where to
we
go.
work really well with her GP. And
you can't be dogmatic in treating chronic conditions. You got to go with what works.
Exactly. So we have vestibular neuronitis, and there are other conditions of the inner ear, like we mentioned, like Maladine-Barkman syndrome is really not an inner ear condition, but it kind of is, because you're up on the boat and you're rocking for so long, and then you get off the boat and then you still feel like you're moving. It's really what we term as a perseveration of vestibular signals, which just means if you perseverate, you keep thinking about the same thing all the time, and that same phenomena can happen with vestibular signals from the inner ear. So there are a number of conditions. I mean, we go into Cogan's and autoimmune inner ear disease. I don't really think we need to do that. The list is like 20 things long, but we hit the major three.
Dr. Gates is talking about the most considered, if you go into the medical model, okay, again, which we're obviously not anti-medical model, but there's a certain protocol, there's a certain model in the medical profession. It puts a high emphasis on the ear. It is relative to either being able to do medicine or do an Epley's maneuver for it, or surgery, and not much else. Okay, and so and those are all focused primarily on the ear, which is why everybody's like, it's my ear. I went to get my ear checked. I was normal. Now they don't know what to do for me, and so on and so forth. So now we're going to get into all of the we don't know what to do for me type of cases, because of all of the things that Dr. Gates mentioned in the beginning as to how this is a global issue. It can be balanced. It can be relative to everything from you having bad feet, peripheral neuropathy, to scoliosis, to just a bunch of things, and you need to find out what the cause is. And then you can actually help correct, or at least vastly improve and control the balance, usually without any medication.
Right.
Would that be accurate?
Yes, that'd be accurate. In the properly selected patient, we'll say it that way. That's our caveat for all things. Because we don't take all patients. We take patients who we see are going to respond to what we do and have something that's going to respond to what we do, basically. And so
that goes to the point I wanted to make in the beginning.
Okay.
So when Dr. Gates says we don't take all patients, okay, what that means is this. And for some reason with balance disorders, this is more prevalent than any other type of patient that we treat. We treat fibromyalgia, we treat tons of peripheral neuropathy, restless leg syndrome, we treat, you name it. All the things that come with that, diabetes, Hashimoto's, celiac, we treated like a bunch of different things. But for some reason, the balance disorder, it's harder for those folks to understand that there's a process involved, that there's going to be a lifestyle change involved, because they have spent their entire time possessing a balance disorder, being told it's their ear, it's going to be a surgery, it's going to drug. So when we start to talk to people about doing vestibular exercises or cerebellar exercises or changing their diet, which Dr. Gates is going to get into here, it's kind of like a foreign presentation. It's kind of like, what? Like, oh, I can live with this. And what you said in the beginning was perfect. You can live with it, but you know, what quality of life do you want to live with? So, so when I'm doing the evaluations, that's what I'm listening for. If I am discussing with a patient, look, you may have to get rid of your 4 or 5 favorite foods in the whole world, because you may test allergic to them, and those may be creating an immune effect attacking your cerebellum, and they kind of go, well, I'm not going to do that. Well, guess what? They're not a candidate for a program, because nothing we can do is going to help them. So I just wanted to make that a little bit more like, we're not going like, well, we don't treat you because I don't like you. It's that there's a certain paradigm that Doug Gates is going to talk about that is proven to be very successful for these types of disorders, and the person has to really embrace it and kind of open up and say, okay, I'm willing to do the exercises, I'm willing to be evaluated properly, I'm willing to fill out your 17-page history, I'm willing to change my diet, I'm willing to do whatever you tell me to do that you find on your specific testing that is contributing and causing my problem, even though it entails way more than taking a pill, once a day. Okay, so I now I'm pretty much done because those are the things that I wanted to get in. I feel it's something important, and so now Dr. Gates wants to discuss that, like the other conditions,
right?
The other main conditions that affect balance.
And really,
there are a zillion.
There's a zillion. And really, in an examination, the whole point of the balance examination is differentiating between inner ear versus brain. That's like the first dichotomy that you just have to do. And we have what's termed video nystagmography, which is a fantastic tool where we video record the eyes. It is the gold standard in diagnosing vestibular disorders in part. And in essence, that really tells us, okay, if someone's eyes are moving in a certain pattern at rest, or if we take them down into a certain position, they're moving, they may move in a pattern synchronous with BPPV, or their eyes may not, and they may have a brain tumor. And I can't tell you how many cases of brain lesions we have picked up just from this examination. So that's step number one. Now step number two, let's say if it's not looking like it's an inner ear problem, it's a brain problem. As Dr. Rutherford said, there can be really a plethora of conditions that are causing that, ranging from tumors and strokes. We've seen those, where you don't get enough blood flow up into your brainstem, as an example. You can have a tumor growing in your brainstem. You can have a tumor growing on the nerve that goes to the inner ear. You can have conditions of degeneration throughout the brain, like Alzheimer's disease. We have a really sweet patient who has Alzheimer's. She had a really difficult time walking. We did some really cool exercises to where she can walk for about 30 seconds. And now we're working with her on her balance, because with Alzheimer's, the brain degenerates so much such that the signals that come from the inner ear don't get filtered. And we're going to go into this in the rehabilitation of balance disorders, just as an example. So every time she moves her head, she gets dizzy.
Because those signals don't get calmed down.
Exactly.
So that they can synchronize properly with her balance mechanism.
Right, exactly. So we're doing new exercises right now to combat that. So there's Alzheimer's disease. There's Friedreich's ataxia, which is another neurodegenerative condition that causes problems with balance. Multisystem atrophy. We had a patient who flew from Germany who had a certain type of multisystem atrophy. It's a type of Parkinson's disease where they primarily have issues with balance. Progressive supranuclear palsy, another type of Parkinson's disease. We had a patient who hadn't walked in 5 years, comes in. Basically, she had the strength to walk, she just didn't have the balance to walk. And so we changed her spatial awareness again. We're going to get into how we did it for where she thinks she is, and all of a sudden she goes from being in a wheelchair to she's walking with a cane in 6 months. So we're not saying that, in an egotistical fashion. We're just letting you know what's possible. And that's not possible for everybody, but that was possible for her.
It was possible for her because we did an evaluation. We evaluated her as a patient. She had all the right things going, and she responded.
She responded, exactly, and that was one of the key factors in our deciding to take her on as a case. So anyways, and then there's peripheral neuropathy, which we've talked about at length in these videos if you've been watching. Neuropathy is really a passion of ours. I think that's the best way to say it, especially idiopathic peripheral neuropathy. Not only diagnosing it, but how to manage it effectively now that we're in 2014.
So numbness, tingling, burning, cramping, essentially in the feet, maybe coming all the way up to your knees, occasionally starting to affect your hands. This affects a lot of the nerves that feed back to the brain, but that's what peripheral neuropathy is.
Yeah, and then so basically, and basically with that lack of sensation in the brain, lose the sight of where the feet are. It's hard to balance if you don't know where your feet are relative to the surroundings. There's also cervicogenic vertigo, for all the chiropractors out there. So basically the neck can be out of alignment.
Yeah, for all of you who've gone to chiropractic, said, well, I just go to chiropractic and get my neck cracked. And I'm a chiropractor. I don't like people say cracked, but I deal with it.
Right.
I went and got my neck cracked and my balance got better. I've seen hundreds of those. I understand. I've been
You saw a lot of
a long time.
patients.
I saw a lot of chiropractic patients. So.
But yeah, and those relationships exist.
And most of them didn't come in for that. Most of them
not.
came in for a stiff neck. They came in for a headache. They came in for something else. And then we're able to, usually it was the upper two vertebrae of their neck, but not always. But most of the time it's the upper two vertebrae of their neck, the Allison axis. You adjust it. The patient comes back a couple of days later and you go, how do you feel? I go, could this be affecting my balance? I'm not as dizzy and my vertigo is less. That's sarcogenic.
Exactly, because there are 90% of the receptors in your body. We're not talking about eyes or ears, but in your body. Dr. Rutherford talked about how each joint has receptors in it. 90% are right up here right in these top 3 cervical vertebral areas and the muscles involved in those
if you've ever gone to a chiropractor who's called an upper cervical chiropractor, or a chiropractor who sounds like maybe a born-again chiropractor, and they will only adjust you here, it's because the gentleman who developed chiropractic, a guy named B.J. Palmer, he spent years working on that, getting all of these seemingly miraculous results. Well, unfortunately, this was back in the 20s and 30s and 40s, when everybody thought he was just nuts, and then his patients were just getting placebo effect. But now we clearly understand what was happening in those particular types of cases. Okay, again, not everybody's going to get those things, but I mean, it can cause dizziness, vertigo, nausea, balance problems, headaches, severe headaches, maybe not migraines, maybe, but a lot can happen up there. Blood pressure, just a ton of things can happen if that's the problem. One of dozens of problems.
And so those are the other conditions that can be associated with balance problems. And we'll go into more on the rehabilitation and what really ties all of them together.
I think the point is that then he could go on for 5 more minutes about other conditions. Exactly. Okay. I think the point to this that we wanted to make is, again, I go back to the opening, which I say, people come in and it's like, well, it's my ear. It's my ear. Well, it's your ear in a small percentage of cases. It's my ear. Why should I go through all this? I went through the tests, and the test said I was normal, and so it's balance is so complex, and that's why the history needs to be exquisite, and the neurological exam needs to be comprehensive and precise, and I'm not talking about machines that look in your ear, not to say that they can't find things, okay? Or I'm not talking about electrical types of diagnostic. I'm talking about a real live, honest to God, one-on-one neurological exam with you sitting there and having every aspect of your nervous system evaluated. That is the only way that your condition is going to be figured out. So since we're talking about that, and everybody, now we've established that maybe it's not always the ear, let's talk about our favorite subject, for sure. Yes. Like in this office, everybody knows what a cerebellum is. Like cerebellum. It's like, what is a cerebellum? Yeah. So why don't we talk about it?
Exactly, and I think one thing that's important to emphasize is that, for most people who, we have a chronic pain and chronic neurological condition practice, we have areas that we go into. If you have dizziness, you go to UCSF, you go to their dizziness center, where that's all those doctors do. So we have focused on this. And so basically the cerebellum is what ties everything together. The cerebellum is the computer that has to create that symphony I was talking about. The cerebellum.
So it synchronizes. You talked about the joints, you talked about the nerves down there, you talked about the eyes, the ears. That's what synchronizes.
That's what synchronizes everything. So basically the cerebellum has to take all those sensory inputs, kind of like flying your plane, and you have the gyro, and you have the pitot probe that tells you how fast you're going, all these different things. Your cerebellum has to take the information from your feet, your neck, your eyes, and your inner ears and collaborate it into figuring out where you are. And then it sends those signals up into your brain so you can also then create this dimensional role of where you are. That makes sense, your spatial awareness. But the cerebellum is pivotal in that. And if you don't have a healthy functioning cerebellum, and our experience and literature shows this, then lots of times people don't compensate for whatever type of lesion it is, whether it be an inner ear nerve lesion, whether it be a visual problem, whether it be peripheral neuropathy. Keep in mind, you can go in and cut the vestibular nerve. Usually if you have
ear nerve, that has a lot to do with your balance.
Like just completely cut it. And in 7 days, most people will feel pretty good.
I didn't know.
They will be a wreck for about the first 5 days, where they're going to be vomiting, constant vertigo, but their brain will adapt, and the brain adapts via the cerebellum largely, if you have a healthy functioning cerebellum. The problem for all of you out there, and this is why I made the point, if you can deal with it, and you've seen it in the consultations, if you can deal with your balance problem, that's really good, you know. And if you're really not that eager to get treated, frankly, we're not as eager to treat you either.
Yeah, exactly. Because it's a continual hassle, and it's an argument. It's why do I have to do this and why do I have to do that? It's like, you don't have to do this. You came here.
Right. Exactly.
You know, but it's not as pleasant, and it's just not it's not a good experience.
And we really enjoy treating the patients who aren't getting better, because lots of times, frankly, they have cerebellar issues, and that's why they don't compensate for whatever inner ear lesion they have, whether it be. We've had people come in here with BPPV who just aren't getting better because they had a bad cerebellum. We have had patients with vestibular neuritis and Meniere's who have done fantastic with what we do because we were able to integrate their cerebellum amongst some other things that we're going to talk about.
So I would edit the sentence in which you said a lot of the times it's the cerebellum, and I would probably say the vast majority of the time.
I'm always so cautious.
It's the cerebellum. Well,
it's involved. It's
okay.
Involved.
So yes. I'm basically, so this is how I do it. This is how I make that determination of saying that sentence. This is what we see. This is what we do.
Right.
How many balance patients comes in here and their cerebellum is not treated? Very few.
And right, and I would say for the chronic balance condition, yes, the cerebellum is.
Yeah. It kind of gets, it's kind of under the strain of trying to synchronize, you know, parts right. That, like you said, I didn't know that. I knew that we went in. I knew that I knew that people went in and clipped the vestibular nerve. I didn't realize that that was the flow, that people got sick, and then at the cerebellum, I didn't realize that, synchronized everything. And that's an extremely clear example of the cerebellum having to do some heavy lifting to try to synchronize that bad ear, and then you remove the bad ear, and now it becomes more able to synchronize everything else. That's amazing. But that is the principles on which we work
right.
in helping pretty much everybody. And when I say everybody, I mean fibromyalgia patients and so on and so forth. It's about getting the balance back in functional medicine. It's about getting homeostasis back. It's about getting chemical balance back. But that also plays into this too.
Yes,
and you can talk about that. So I mean, again, you can tell I like this subject because I just think it's just such a misunderstood subject, and so many people are living with this stuff that don't have to be living with it, and they probably don't want to enter into the type of protocols that we do sometimes because they just don't believe it's going to work. And they just think, wow, I'm going to do all that, and I have to change my lifestyle, and I have to do this. I just keep taking the pill.
Right.
Or I'll just stay dizzy every now and then and deal with it.
Mm-hmm.
We see that a lot. So more about cerebellum? I mean...
Yeah, and I really got to give credit to Dr. Carrick. I mean, he was the one that came up with this. Come up with it, I don't know. That's the best way I can say it, because he really focused on the cerebellum. The cerebellum is this nebulous entity in neurology. We know that there are cerebellar disorders where you can get a tumor on your cerebellum. We got to cut it out, or can we not cut it out and you're going to die? Something like that. That's how neurologists look at the cerebellum for the most part. Dr. Carrick has looked at it functionally, and that's a very difficult thing. Perfect case in point. When you study movement disorders like Parkinson's disease, they'll talk about the anatomy of the part of the brain involved in Parkinson's disease. It's called the basal ganglia. It's very intricate and has really even more intricate functional connections. And then they'll say, at the very end of like 2 chapters, they'll say, and we think the cerebellum has equal importance in these neuronal networks, but we just don't understand it as well. Which I think is hilarious. Maybe you don't out there. But Dr. Carrick has really figured out the cerebellum, in our opinion. And for us functional neurologists, we're blessed to be able to have had that type of training, and we know that it's an emerging therapy. But what we're seeing clinically when we properly select a patient who has something like vertigo or dizziness or lack of balance, and we apply these principles that we're going to talk about, of getting the cerebellum to work better so that you can compensate for whatever the vestibular nerve lesion is or neuropathy in your feet, some really cool things happen.
And for the record, okay, the police have figured out what the cerebellum is. And if you want to know what the cerebellum is, it's here. It's located here. It's 2 little lobes here. Cerebellum means little brain. It synchronizes everything, and it's also extremely sensitive to any type of changes in your chemistry, blood sugar, stress hormones. But it is notably also significantly affected by small amounts of alcohol. So if you've ever been stopped and given the drunk test, and they have you trying to touch your nose, and they have you trying to stand there and walk a straight line, that all those are functions of your cerebellum, and because the alcohol can affect it so drastically, which is why when Dr. Gates is doing neurological function relative to these, correcting neurological function relative to cerebellum in the inner ear and peripheropathy, whatever is the cause of that, it is the reason why the diet and your metabolism and whether you have blood sugar problems can be so important, because these physiological entities may be perpetuating a bad effect on your cerebellum, which may be perpetuating your inability to get better, or may even be perpetuating the fact that you're getting worse even though you're taking the medication and you're doing these types of things. So.
Exactly, so that's where we're going now.
Well, let's go there.
Okay, so we have to credit Dr. Hajivasulu, and forgive us, Doc, if we're mispronouncing your name. He's out of the United Kingdom. He's from England. He's a neurologist who has done most of the work, or the foundational work, in the study of the immune responses to the cerebellum. We have known for some time that cancer in the body will cause the immune system to attack the cancer, trying to get rid of it, and in that process, the cancer looks like the cerebellum, then your immune cells will not only kill the cancer, but they'll kill the cerebellum. Those are called paraneoplastic syndromes. So we knew that the immune system could be involved here, but Dr. Hajivasulu has blown the barn doors open on this whole field now termed gluten-related disorders, where we're seeing that a lot of neurological conditions can be secondary to the immune system, immune responses to gluten, or immune responses to something else that we're going to get into.
And the reason that Dr. Gates says he's blown the door off it is, even though gluten is becoming, 5 years ago, even 5 years ago, we talked about gluten, and people were like, you guys are nuts, and it's baloney. Now, it's kind of become more aware. People think it's a fad. It's not a fad. The science world still is starting to embrace it more and more, but this is a huge, huge aspect of many types of balance problems and perpetuating them. And when he said Dr. Hajivasulu blew the door off it, it's because he is a very prominent neuroscientist,
and neurologist, and neurological
researcher, who has a lot of street cred in the neurological world. So, so what Dr. Gates said is very important to any of you who have these types of conditions.
Because this really all goes back to, why are you having this chronic balance problem? We discussed, you can cut your vestibular nerve. You should be better pretty much in a week. You should be compensated. If you're not compensated out there, likely your cerebellum is weak. If your cerebellum is weak, we have to beg the question, why is it weak? And in our experience, commonly it's weak due to these immune system abnormalities. And that's why when I got into practice 5 years ago and I joined Dr. Rutherford, I came and I was trying to apply these functional neurology techniques, and they work great sometimes, and they didn't others. And when they didn't work, it was usually in cases where there was an autoimmune issue, until we figured out that we had to handle the autoimmune issue in conjunction with trying to stimulate
the biochemistry, the diet, the blood sugar, all that kind of stuff.
And so however you want to look at it, if your immune system is killing
your immune system.
if your immune system is killing your cerebellum, you can go and try and exercise the cerebellum until the cows come home. It's the same analogy as if your immune system is killing your muscles and you have a polymyositis, that's that condition, and you're trying to exercise your muscles, you're probably not going to get the same results as if your immune system was calmed down. And that's what we're seeing here. And the reason why we mentioned Dr. Hajivasulu is because he brought knowledge to the gluten antibody issue, which is big. It's called gluten ataxia. We also see that these gluten antibodies can attack to the cerebellum, or attach to the cerebellum. It doesn't necessarily have to cause ataxia, but it can cause problems with balance and things of that nature. But also things like thyroid antibodies, which 15% of the female population has at too high of a level. We're seeing that these thyroid antibodies can have cross-reactivity to the cerebellum. We're seeing these things called GAD antibodies, which can cause or be associated with type 2 diabetes, or they can be associated with this thing called stiff person syndrome, or they can just attack the cerebellum haphazardly. And we have a case right now. This gal developed diabetes. She's 60. All of a sudden, she's on insulin. Sorry if that snap was loud. And she has this nausea, this dizziness that wouldn't go away. We ran GAD antibodies on her, off the charts. She's now doing really well. Not doing really well.
So if you have diabetes type 2, if you have diabetes insulin resistance particularly, then or if you have the thyroid, 15% of thyroid that Dr. Gates was talking about is called Hashimoto's thyroiditis, if you have something like that. But frankly, it's almost like, to me, it feels like the way it's going, it's almost if you got any other type of autoimmune problem,
yeah,
and you have balance problems, it's worth running those to see if those are a big part of your problem, because it's not uncommon.
Right. It's not
uncommon, but your doctors, for the most part, I'm going to guess, probably are not going to evaluate for that.
Yeah, I just haven't seen it evaluated that commonly. I mean,
that would be a good way of putting it. I said it very
more
sensitively,
right.
because I do the intakes, I do the initial consults, I do part of the initial exam, and I don't see anybody being evaluated for it.
Relative to the balance world, not yet.
And it's huge.
And you know, we do these videos, and we have people email me from all over the country with their conditions. I just had a case of neuropathy where the neurologist ran gluten antibodies to see if that was causing her neuropathy. I thought that was awesome.
That was awesome.
Because at least that's getting out there. But we have not seen that same type of workup yet in the balance world. We have a patient right now, 18 neurologists and ear, nose, and throat specialists. We're not saying this in a self-laudatory fashion. Just as an example, had a vestibular nerve lesion, comes to us, and she has huge gluten antibodies, gliadin antibodies that are affecting her cerebellum, and that's likely the reason why she doesn't compensate. She goes on a gluten-free diet and some other dietary interventions, and all of a sudden she's feeling better.
Yeah, and it's not that we're smarter. Well, he might be, but I can speak for me. It's not that we're smarter than your medical doctors or your neurologists or anybody. It's just that they have been trained in a certain model, and that model is centered on the inner ear. It's centered on the inner ear. It's centered on specific testing that is covered by the insurance. It has almost no training that I'm aware of relative to the types of things we're talking about, relative to diet or gluten sensitivities or antibodies to the cerebellum. That is a functional model. I don't even want to call it alternative model. I frankly don't consider us alternative, although everybody comes in here does. But I really think this is going to become the paradigm, not just for balance, but for chronic pain. I say that because we consistently see good results with what we're doing. But it's not a model that fits in with your doctor's model. It doesn't fit in with the 5-10 minutes that are allowed for a history. I mean, understand, we talked about a lot of things here over the last, let's see, 30, 45 minutes, 30, 40 minutes. And those all have to be evaluated. They all have to be evaluated. We have a 17-page history form. And by the time that patient, and it's a check sheet, it's not hard to fill out, but the bottom line is that people go, oh, 17. You probably did it when I said that. Okay. But the bottom line is this, it is a very precise document that narrows things down dramatically. And then Dr. Gates says, in my opinion, and I've done neuro exams, we're probably one of the most thorough and accurate neuro exams I've ever seen. And he's focused on this, and then I come in and I look at that and at that 17 pages, and we talk about that, and then we can kind of tell, does it look like a thyroid's involved? Is there? And after you've done it for a while, you start to see these patterns. They just start jumping out at you. This is just a different model. This is the functional model. This is we're going to do it every which way we can without drugs type one. Not because we're anti-drugs, but because this is a more long-term solution that is now being determined, and it's fully supported in the literature. If you watch any of our presentations here, I mean, Doug Gates has like anywhere from 10 to like 30 references for every presentation there, and there's way more. And there's way more. He only puts certain ones on there. So it's in the literature. It's in the science. It's validated by some of the top researchers in the world, like this Dr. Hadi Sadhu. Hadi and others that are just icons in their field, but they're not. It's not research that lends itself to the medical model, and I don't think the medical model is trying to change. I mean, I'm seeing it, like you said, but they're still going to run gluten antibodies. Now, if that's not there, now they're kind of done. Now they're kind of done because there's a lot of other things you need to look for. And if you do the history and you do the exam, frankly, you know whether to look for them or not.
Right, exactly. And that's the whole point of the testing.
Yeah, and that's the whole point of testing. Where in the medical model, testing is there. Everybody comes in here. Well, here's my ear test, and here's my blood test. Some people come with blood tests, not so much on these balance disorders, but they should. and then they say, well, okay, here's my testing, here's my testing. The medical model uses testing to establish diagnoses. The functional model uses history, exam to primarily establish diagnoses, and then it uses the testing to figure out how to fix that person. It's much more specific testing to their physiology as opposed to their diagnostic code.
Right, exactly.
And I don't know if that made sense to you or not, but I'm just trying to draw the point of we're not cutting down your doctors. This is just, we're just educated in a different model that has been produced for these very types of things that we treat. And in the medical model, it's still, let's do pain management if you have pain, and it's still, let's do you know, for vestibular stuff, let's do Epsleys. Well, that didn't work. Okay, let's do medication. Okay, that's kind of working okay. I know physical therapy is starting to use some of the vestibular exercises,
right,
but very generally from what I can gather. And so this is something that requires a very specific examination to get a very specific understanding of what your brain and the rest of your neurology is doing, as Dr. Gates stated in the beginning. This is very complex. Now, once you find it out, which is not that easy unless you are well schooled in this, once you find it out, the pathway to success becomes clear, and you can apply the certain things that need to be applied and bring that patient through it and usually get a successful outcome. Mm-hmm. But it's just a whole different animal.
It really is, yeah. And on the physical therapy note, I mean, it's just a different concept or paradigm for how to apply these exercises. They're really trying to force your brain to adapt, and that can work if you have a healthy functioning cerebellum, but then if you have a non-healthy functioning cerebellum, in our experience, sometimes you have to go slower. The analogy is if you haven't worked out in a year, you don't want to put 400 pounds on the bench press your first day there. You're probably going to tear something.
Yeah, I mean, it's similar to, like, I used to live in an area where there were a lot of pilots, and they would tell me how some of them were sick, and they would put them in these machines.
Right, yeah. My best friend went through that.
Okay, just to basically.
And he couldn't pass.
And he couldn't, yeah, some of them couldn't do it. I know I couldn't have done it. I had a few issues with concussions and things of that nature.
Which we're going to talk about next in our snippet.
Okay, yeah. Okay, which we're going to talk about next. But I couldn't do that. There was no way I could do that. I wouldn't even try to do that. But that's what Dr. Gates was talking about with the physical therapy stuff. Mm-hmm. And it works in certain cases. It's like, and I'm a chiropractor, 35 years, just like the manipulation works in certain cases. But it's better to understand what the box is. Here's the box, and these are all the things that can cause this. And then it's built into a history form, that 17-page history form, and a verbal history that we take when you come here, in addition to that. And then within the framework of that exam, and then you now look at that box and goes, well, it can't be this, this, this. These are only two things it can be, or one, or three. And now you test for that. And it's pretty successful, but it takes work. It takes some time. It takes a good, heavy background in neurology that is a little different than the background that the neurologist gets, because the therapeutic intention is different, and so it's just different.
Exactly. I mean, because so much of that residency for becoming a neurologist is about titrating medications. The neurological diagnosis aspect is the same for anybody who's working, and right, whether you're a neurosurgeon, neurologist, or you're what we do, even though there's not as many of us and we're not as well known.
Right.
But then it takes a lot of skill to use a lot of these medications for, like, Parkinson's disease and things like that. Whereas what we're doing, we're not using those medications. We look at the brain completely different. We look at how you stimulate it to bring it back to life, or to calm it down. Exactly. Through certain exercises that are very specific and very well researched. Very well researched. So yeah, it's a completely different craft.
So I think that kind of.
I agree.
I think that kind of covers it. And I really believe that you probably. I mean, there's way more you can tell. He's got 2 textbooks sitting here. There's way more things that cause balance disorders than what we've discussed. But Dr. Gates shared with you enough to give you the concept of what you're up against if you have a balance disorder. Really, what you're up against initially is just getting a proper diagnosis. That's the biggest thing you're up against. Second thing you're up against is, is this something I want to do? Do I want to really, like, if I have gluten sensitivities, do I really want to get off of gluten? Do I really want to change my lifestyle? Do I want to do these exercises 3 minutes a day or 4 minutes a day, 3 times a day? Or do I want to go through a couple of months of rehabilitating my brain and my body the same way I would go to the gym and rehabilitate. It really comes down to that in the end. But it all starts with as accurate a diagnosis as possible, and that can only be done through an intense and very specifically directed history and a very, very comprehensive and very specific neurological exam. And I'll stand by that statement because that's what we have found, and our success rate is pretty. I think it's pretty darn good. So
yeah, with the properly selected patient.
With the properly selected patient, exactly. So I hope that was helpful. Send any of your questions to him.
At powerhealthtalk.com. www.powerhealth.
And I'll make sure he answers them.
Or send them to our Facebook page.
I'll beat him with a stick or something like that. Or go to our Facebook page and yeah, that would probably be it.
I would agree.
Yeah, that would probably be it. Okay. Until next time.
Thanks for watching.